the College of General Dentistry in association with the British Association of Dental Nurses to actually say, well, can we please defer this mandate from going live to give our workforce and our profession a chance to get these vaccinations, because it is going to have an impact on our patient care going forward. So please ask those questions. We've got a wonderful panel who are going to be able to address these concerns of yours. And I'm going to hand over to Jason now to kickstart the conversation. Thank you.
Ashveen, thank you very much. And thank you for having me, everybody. Robert, thank you for the invitation. And it's wonderful to be in this good company. I don't know everybody well. Steve and I know each other relatively well, although we've never actually met in real life. We've only ever met online at multiple versions of either this or the advisory groups on which we both sit to help both the Scottish and the UK governments. So I'm Jason Leach. I'm a dentist. I was then an oral surgeon for many years, and then I did a kind of transition to government. Long story short, I became the National Clinical Director of the Scottish Government a number of years ago. And 2 years ago, the global pandemic arrived. And I was in the seat when the music stopped as the third clinical advisor to the First Minister of Scotland and her cabinet. So we have a chief medical officer, a chief nursing officer, and a national clinical director. And there was a kind of famous day now when there was about 6 of us in a room when we were discussing what this virus was from Wuhan, China. And the First Minister and I have known each other for many years because she was the health secretary and I was the head of patient safety at the time. And we were kind of distributing tasks in February 2020. And she looked at me, and I absolutely swear this is what she said. She said, "What on earth are we going to do with you?" And I said, I've absolutely no idea, but you can choose. So she said, "We better put you on the telly." So I ended up being kind of one of the public faces of the pandemic. So I have been the external and internal communicator of the clinical advice, or tried to be. And I've done that with Gregor, who's the chief medic, and Catherine before him, but also a lot of kind of hidden engagement with stakeholder groups. So faith and belief groups, the business community, the sports community in Scotland. So not quite as public, but yeah, a lot of time doing that. So I'm delighted to be here. I'm going to just spend 5 or 10 minutes introducing the subject of the pandemic and vaccination. And then I and everybody else, I'm sure, are happy to take it wherever you need it to go. Not to spare us blushes, but we have one of the UK's foremost experts in behavioural science in Steve. So anything you want to know about how to persuade a population or an individual to do something or not do something, then Steve will have views, and I will give my views. Remember, I work for the Scottish government, not the UK government, so I have to be slightly careful what I say in both of those directions, but I will tell you the truth as I know it at the time. But let me just start here, and somebody can interrupt if they don't see slides or they don't hear me. Robert, you can let me know. This is the present state of the global pandemic. If you think this is something you've seen before, you've misunderstood. There are 5.5 million dead. There are 320 million with a positive test. Now, that's a gross underestimate, almost certainly. The Economist has just done a piece of work looking at actual deaths from COVID, and the Institute for Health Metrics and Evaluation have done their own model. So whichever model you believe, it's somewhere between 15 and 20 million dead. This is like nothing we've seen in our lifetimes. I actually have a pal who's turning 103 this week, would you believe? So she remembers the tail end of Spanish flu when she was born, but none of the rest of us have any concept of what this is. And when it started 2 years ago, none of us knew what it was. The WHO think we're about halfway through, roughly. So they think their best estimate is pandemics last about 5 to 10 years, and we're 2 years in. So with a fair wind, we're about halfway through. This is the position on January the 24th. Dark is bad, light is good. This is principally Omicron, but not only Omicron, and it relates to the cases per million people. you can see Argentina, the US, Greenland, Australia now in some trouble, Western Europe beginning to lighten a little, although France still in significant trouble, and the Omicron wave going east because we got it after South Africa, and it is moving eastwards to Eastern Europe and in geopolitical terms heading to Ukraine, as if they didn't have enough trouble. And you can see in Scandinavia also some challenges. Africa is the wrong color. There's not a lot of testing between North and South Africa. So sub-Saharan Africa, we actually don't know what's going on for much of sub-Saharan Africa. There are stories to tell in each of these countries, which is a whole different webinar. This is the UK position, the latest UK position. This is the Office for National Statistics data, which is the closest we have to true numbers. This is a survey where they go to people's houses, 64,000 houses a week. They come to your house, they do a PCR test, they do a blood test, and they ramp that up to the whole population, and they do that across the 4 UK countries. It varies. You get confidence intervals for the statistics, of course you do, but these are the most recent data published yesterday at midday. And Scotland has a percent positive in the previous 7 days of 3.11, and England has a percent positive of 4.82. That equates to around 163,500 people had the virus in Scotland, and 2.6 million had the virus in England. If every 0.5%, well, let's do it, let's make it easier. Every 1% in Scotland's numbers is 50,000 positives. Every 1% in England is 500,000 positives. So these small differences in percentage point actually make quite a big difference to the number of people who have the disease. So let's transition to vaccination. I'm happy to talk about hospitalizations and mortality if that's where the questions want to go, but let's transition quickly to vaccination since that's our subject. These are Scotland's data. The numbers are not dissimilar across the 4 UK nations. This is booster doses. So this is 3rd doses in most people, 4th doses in the immunosuppressed. Remember, the primary course in most of us was 2 doses. The primary course in the immunosuppressed was 3 doses, and then a booster more recently. You can see by age how this has happened. Pretty much everybody over 60 is done. And then it begins to tail off a little as you get a bit younger. Some of those younger individuals are not yet eligible. So that's why those numbers are a little bit lower. And in the very elderly, the over 80s, some of them are not eligible because they're in end-of-life care or have a serious disease. So those numbers are astonishingly high. If you told me we would get anywhere near mid-90s for booster doses for a vaccination, I wouldn't have believed you. We were doing 75,000 injections a week in the 3 weeks leading up to Hogmanay. It was an astonishing exercise, both from the National Health Service and from those coming forward. This is the global vaccination data, and it tells a completely different story, I'm afraid. This is the number of injections given per 100 people around the world by the 25th of January. The light is a low number, dark is a high number, you can see. So we've given about 200 doses per 100 people. Chile has given almost 300 doses per 100 people, and Cuba, which has the best vaccination program in the world, has given 300 doses per 100 people. So they are fully boosted. In Malawi, they've given less than 10 per 100 people. So there is huge vaccine inequity around the world. Some countries aren't through dose 1, and some countries are on to 4th booster doses. Israel, Cuba, some of Western Europe. You get the idea. Australia and New Zealand, also interesting stories all of their own. This is the best and most recent data we have on lives saved. This was a massive piece of research done across Europe from the WHO regional office, from Edinburgh University principally. And what it did was looked at the number of people who would have died with COVID before vaccine, and then it estimated how many people should have died, compared that with the number who did die. And that is 470,000 of a difference. Now, there is confidence intervals in there, of course, but they're not huge. It's pretty accurate data. So that's 470,000 fewer deaths than we would have expected without the vaccination programme in 33 countries across Europe. In Scotland, we were the second highest in this, proportionately, in this list, and we saved 27,000 lives. So 27,000 people alive who would have been dead. Just go back a little bit to what vaccination is. Vaccination is the single biggest lifesaver after clean water in public health history. These are three examples: diphtheria, whooping cough, and measles. It takes some time for vaccines to disseminate through the population, for the population to accept them, and then them to have a population effect. And you can see what's happened. Diphtheria is gone from Western Europe. You do not get diphtheria in Western Europe anymore. You get a little bit of whooping cough, but very little. And you get almost no measles, although unfortunately, some conspiracy theorists and some damaging publications and literature did cause measles to rise again across some of the developed world, but we appear to have got a grip of it. So it's fairly simplistic, but let's think about what the vaccine actually does. The vaccines all behave very similarly. We've now got 3 in the UK. We'll probably get a 4th in 2022, maybe more. Basically, the vaccine pretends to be the virus. It is a little piece of the virus. The body produces an immune response in 2 ways. It produces a cellular response using T cells, and it produces a humoral response in antibodies. And they wait for the actual virus. The vaccine is not the virus. You cannot get the disease. It is impossible to catch the disease from the vaccine. But fundamentally, we take a little bit of the virus, we make it in the laboratory, and we give it to you to pretend we've given you the virus, and your body thinks it has, and it makes the immune response. And then when you meet the actual virus, you attack it, and you live, or you don't end up in intensive care. So we have massive reductions in intensive care admissions and hospital admissions and deaths as a result of this astonishing science. One of the crucial questions is, how did you develop vaccines so quickly? Because traditionally vaccines take over 15 years to go from original design to regulatory approval. And it's an excellent question. Fundamentally, the process was compressed, but not safety removed. So everything that happened in exactly the same way. We just did it fast. And we did it fast really in 2 ways. We invested huge amounts of money, and we did it globally rather than locally. And governments underwrote the drug company risk. So normally you would do a very small study because you don't know if it's going to work, and you wouldn't invest in production, because why would you invest in production if you don't know if your vaccine's going to work? So governments basically said, we will underwrite the production values, we will buy the vaccine. If it doesn't work, we'll throw it all in the bin. But fundamentally, you can compress your trials into shorter periods. You can overlap them, and we'll do the regulatory approval just as quickly as we can, because the world needs this vaccine. So that's what happened globally with Pfizer, with AstraZeneca, and Moderna. And each of them has a fascinating story of their own. The Pfizer vaccine, made in Turkey by Palestinian immigrants in global laboratories all over the world. It's an amazing story of both public-private partnership, but also of global research coming together to solve the great question of our day. Can you make a vaccine that will save hundreds of thousands of lives around the world from a killer respiratory virus? Now, in the UK, we have 2 organizations who then decide if we can use it. We have the MHRA, who decide if a vaccine or a drug is safe to use. And then we have the Joint Committee on Vaccination, who decide how it should be used. So question number 1 is safe, yes or no. The MHRA answer that on behalf of the 4 UK countries. And then the second question is, how should you use it? What age should you give it to? Should you give it to kids? Should you give it to care homes? Should you give it to boys rather than girls? How should you do it with the state of your pandemic, the number of people you have infected, and your population demographics? and the Joint Committee tell us how to do that. They use data like this to make that choice. So these are number needed to treat data. So the number of people who have to have the vaccine in order to do something. So if you're over 90, you need 40 people to prevent one death. So you need 40 90-year-olds to have the vaccine to prevent a single death. If you're 50, like me, I'm 53, you need 40,000 people at my age to prevent one death. You can draw that data in a number of ways, but this is basically the graph of risk. So number vaccinated versus risk of death. This disease is a disease of the immunosuppressed, be it by age or disease. So as your immunity falls, you get more risk of COVID. That could be because you're elderly. It could be because you've had a kidney transplant. It could be because you're HIV positive. So that graph tells you who to do first. And that's what we did. We did care homes. We did care home workers and residents. We did healthcare workers. We did others on the age grade round down, all the way down. Now, this is where it gets a bit tricky, and this may be where we end up in the questions. There are basically two principal groups who are hesitant about their vaccine. There are true anti-vaxxers. Now, those true anti-vaxxers are in the street in Glasgow on Saturday with a very small but loud march. There's not a lot I can do about them. They have gone down a dark tunnel of conspiracy theory, and they are only listening to the voices who they believe to be true on social media and in other places. And actually, it's probably a waste of energy. But the big group who are perhaps vaccine hesitant are a group worth spending time on. And that's where Steve's expertise will help us a lot. Those who have genuine questions about maternity services, about what the vaccine is, about what the vaccine will do, about long-term effects, about allergy, about what I should do if I'm a pregnant woman, if I'm having IVF, all of those questions, completely legitimate. If you want to know more about that world, some of it is a little bit boffin and geeky-like, but there's a very good organization called the Vaccine Confidence Project, run by an American, and they've got lots of data and expertise on increasing vaccine confidence in a population, whether it's a professional population like this one or a country. So the most vaccine skeptical group in Scotland is the Polish community, because Poland is traditionally quite vaccine skeptic, and the Poles in Scotland get their news from Polish newspapers and Polish radio stations. You won't be surprised to hear it's exactly how I would behave if I was in Poland. I would still read the Herald and listen to Good Morning Scotland. Maybe not, but you get the idea. So the Vaccine Confidence Project helps you understand what that might be. Just in closing, Tashveen, these are some new data that I thought this group might find quite interesting. And a little busy, I'm just going to talk about the first and the second image here. I didn't have time to make them a little bit bigger. These are new data about vaccinating children. So these are the countries that are now vaccinating 5 to 11-year-olds. The UK hasn't made this choice yet. The Joint Committee on Vaccination continues to review the data, but Canada has now done almost half the kids, Spain, nearly half, you get the idea. And then the middle one, which I thought was quite interesting. So this is a survey of countries and support for mandation. Now, Scotland has not mandated a vaccine anywhere. England, as you know, has mandated a vaccine in health and social care. We have chosen not to do that for now, and we have no plans to do so. But these data are quite interesting. This is, do you think there should be mandatory vaccination for all adults? So in Italy, nearly 60% say yes. In the UK, a third say yes. When you ask about mandatory vaccination for healthcare workers, 2/3 of the UK, nearly, say yes, and 80% of Italians say yes. It just gives you some idea of where the public are. The final graph on the right-hand side is about vaccine uptake following COVID certification and showing a significant increase in 3 countries. And then my very final point is about what you can do in a country if you are vaccinated or if you're unvaccinated. It's a little complex, this, but if you look at the one with the dots, countries down the left-hand side, and this is a stringency index. So this is something that Our World in Data and the ICJU have been using for a little while. So how strict is your country? And the vaccinated are allowed to do what's in the blue dot, and the unvaccinated are only allowed to do what's in the purple dot. So they have more stringent restrictions. And you can see in England, the least strict, both vaccinated, unvaccinated. Scotland about mid-table, both vaccinated, but the unvaccinated, there are some restrictions because we do have COVID certification in some places for the unvaccinated. So you get the idea. So Tashveen or Robert, whoever's going next, that was my short introduction. Over to you.
That's brilliant, Jason. Thank you so much for that. Tashveen, I'll pass over to you. Okay.
Thank you very much for that. That was really insightful. Excellent slides, which I want to use again. So I'm going to go to some of the questions now around efficacy of the vaccine. And one of the questions that came through was, will I need to have a booster every 6 to 12 months?
Want me to do that?
Yes, please.
Yeah, so we don't know, but the first booster doses in the UK were given in October. My parents were boosted in October, they're 81, and we're beginning to show waning in their vaccine response, not their individual vaccine response, but the population vaccine response. The Joint Committee on Vaccination will decide when another booster is required. If I were a betting man, I would think a 4th dose for the elderly and care homes in the spring. I think the rest of us may be able to stretch that to the autumn. And then I think there will be an annual vaccination program for COVID on an ongoing basis. I might be wrong. It might need to be more often than that. The immunologists will tell you that immunity builds up. So each one you get kind of turns the dimmer switch up a little, and it doesn't go right back down again. It goes down, but it doesn't go to where it was. So you get long-term immunity over time. So I would expect a 4th dose for most people, a 5th dose for some in the spring, and I would expect a 4th dose for the rest of us, probably in the autumn leading into winter and flu season.
Do you think the healthcare professionals would come under that spring cohort to say?
Perhaps it'll depend on risk. So it'll depend on what the virus does and what the state of the pandemic is at the time. So when you have a tricky question, which that is, you set up a group of boffins to answer your tricky question. Yeah. And in the UK, we have a group of boffins called the Joint Committee on Vaccination. They have served us very well. I have sometimes disagreed with their pace, sometimes even with some of their decisions, but they have, as you look back, their choices have almost always been absolutely right. And their timing has been excellent. So tricky questions, you ask the boffins. So the boffins will let us know when to vaccinate again. So
the JCVI are the people to watch out for.
They are.
How effective is the vaccine if you've already had COVID?
It's very, very effective, and you should have it if you've had COVID. Natural immunity and vaccine immunity are slightly different things. They behave slightly differently. So the dimmer switch, which is the way of describing immunity, will be turned higher if you get the vaccine after you've had natural immunity. Natural immunity is not the way to deal with this disease. You do not want it. It may well pass through you relatively easily. It may not, of course, but you may well pass it on to somebody who can't deal with it quite as easily as you would expect it. So if you've had the disease, you should absolutely get the vaccine.
Okay. That was going to be my question about natural immunity. So herd immunity, we don't agree with that, or?
Well, it's become a little bit of a kind of iconic term and misunderstood. Let's switch it to population immunity. Population immunity is one of the ways we will recover from a global pandemic. There isn't any question about that. The more immunity we have as a population, the less harm will be caused by the virus. So therefore, my vaccine matters to you. So my diabetes doesn't matter to you. I'm not diabetic, but if I were, or my asthma doesn't matter to you. You don't care about my individual disease, my cholesterol, which is maybe a more accurate disease to choose for a West of Scotland boy, doesn't matter to you. But my vaccine does matter to you, because population infection is the way we get through this. So if we can be population protected, that's how that's how we got rid of smallpox. It's how we get rid of other diseases like measles. We protect the whole population, and that protects those most likely to suffer and die from this particular disease. So we do believe in population immunity. What we don't believe is sacrificing the elderly to save the young. Yeah. That's what herd immunity became at the beginning, that the headline was, just let it run through the country because then we'll all be protected. The problem with that theory is you kill the vulnerable.
Okay. I just want to move on to a couple of stories now. So I wanted just to reach out to Diane. With regards to sort of dental nurses, dental hygiene therapists, and just the general dental professions who you represent, what are their main concerns and issues that they've raised?
Well, we actually surveyed our members a couple of weeks ago in preparation for this webinar, actually, and so it was quite mixed, the concerns, but I think from our point of view, obviously being a female-dominated profession, there's a lot around questioning about fertility and not those kind of issues, really. I think those seem to be the main ones, really, and then obviously just real general kind of health issues that could be caused because of with regards to the vaccine.
Okay, so Jason, do you feel that there's any evidence around the impact of the vaccine on fertility and pregnancy and other health conditions?
So this is a fairly easy one to answer, apart from your stroke, other health conditions. So let's come to that bit separately. Let's deal with fertility first. There is no biologically plausible mechanism for fertility to be affected by any of the available vaccines. None, not one biological plausible mechanism. There is no mainstream public health person or obstetrician in the developed world who thinks the vaccines affect fertility. Not a single one. So it can be completely discounted. Now, the problem with that, and Steve might have a view, is me just shouting that doesn't seem to work. So that's the truth. And it's unusual to have such clear truth in medicine. But that is the truth. But just repeating that to people who have this risk somewhere in their head because they're either pregnant or wanting to be pregnant, to understand that, we have stopped, I mean, we don't do this lightly, we have stopped IVF in Scotland for unvaccinated women. So that's an enormous decision for us to make. And we've done that to protect the women and the unborn children. Now, for us to make that choice, to do that for unvaccinated women, if we thought there was any reason that pregnant women or those wishing to be pregnant were at risk from the vaccine, there is nothing for us to gain by vaccinating them. So there is no plausible biological mechanism for fertility to be affected by the vaccine. But Steve might want to tell me why me shouting that doesn't work.
Can I pull you in, Steve?
You're muted, Steve.
Thanks so much, Jason, for that hospital pass in so many ways. I should say, incidentally, if you don't live in Scotland, you don't realise that Jason, I think, has achieved the status of national treasure. He's a bit like a mix between David Attenborough and the Crankies. I mean, he's a man who is known to everyone and loved by everyone.
Well, not quite everyone, but I appreciate you. I appreciate the sentiment.
Let me go back a bit to the different groups who aren't vaccinated. I would elaborate it in a slight way from Jason. I see there to be three groups, in a sense. One group is what you might call the vaccine indifferent. They don't have any questions. They just couldn't be bothered. They haven't got round to it. There's a very simple correlation between how far you live from a vaccination center and whether you get vaccinated or not. Okay, it's not the only factor, but it's a factor. And for them, actually making it easier, giving them a reason to get vaccinated, they'll get vaccinated. Then you have the vaccine hesitant. Okay, now it should be said that actually they are quite a small proportion of the population overall. Overall, they're not much more than about 4%. And the anti-vaxxers are a tiny, tiny group. Now, in many ways, what we're dealing with is actually a situation where what we're trying to do is to persuade and convince the vaccine hesitant, people who've got genuine questions. At the same time, the anti-vaxxers are trying to persuade them. Right? And the anti-vaxxers narrative actually is a very simple and very clear narrative. And it's quite a politicized narrative. It's the same narrative that is central in a lot of populist politics. It simply says there is an establishment which doesn't care about you, which is out to get you, which is out to control you. This notion of control is absolutely central. And if you look at many of the conspiracy theories, actually they're more like metaphorical stories. The detail doesn't really matter. They're just ways of saying they're trying to control you. And if you can show that that conspiracy theory is untrue, they say, well, okay, but they're trying to control you in other ways, that they are poetic truths. Okay. But the crucial issue is, how do you persuade people that you're not trying to control them? Okay. And in the end, in many ways, it's not about the information. We often think that when it comes to these issues, they are about the information and the quality of the information. But in many things in life, and that includes vaccines, we aren't experts, and we know we're not experts. We're not vaccinologists, we're not virologists, and so on. So the key issue is, who do we trust? Trust is absolutely central. It's about your social relationship to people. Now, the first thing to be facile is shouting at people never works in that context, because if you shout at people, you're not having a dialogue with them. You're imposing on them. You're acting over and above them. You're trying to control them. And what does that do? Well, it reinforces the anti-vaxxers narrative. You see, they're not going to listen to you. They don't respect you. They shout at you. So the question is, and it's a profoundly psychological question, is how do you rebuild that trust? How do you make clear to people that what's being done is not being done to them, but is being done for them? Now, there are a number of ways in which I think that becomes central. The first, and I understand, that when somebody isn't vaccinated and they might take up a hospital place which you sorely need, it's very easy to get angry and say, you're an idiot, you're a fool, you're selfish, okay? But at the same time, it's entirely counterproductive. And I think the first thing I would say is respect is critical. People have got the right to have questions. They should have questions. Nothing unreasonable about the fact you want to ask questions if you're going to inject something into your body. No problem with that at all. The real anti-vaxxers don't have questions because they think they know the answers, right? But if people have questions, respect those questions. Listen to them. Try to understand what their concerns are. Try to understand what's going on in their lives, because everybody's got unique circumstances. So they might say, well, you can give me these broad statistics, but what about people in my personal circumstance? So I think I would say that the starting point is respect, trust, taking time, listening to people, allowing them to come and see you, to go away and to come back. That's the first thing. And the second thing is, when it comes to trust, of course, who communicates is absolutely critical. Right, the source of communication. So having communicators who are seen as part of us, part of your own peer group, people who've got the same experiences as you, is really powerful. So, other women who have had issues of fertility are going to be powerful. Women who haven't been vaccinated and have had to live with the consequences, and their children, and the consequences of their children, those are going to be powerful communicators. So I think the critical issue is, if you have this issue, an issue of misinformation, don't think it's about information. start from the premise it's about a social relationship. How do you build that social relationship? It's partly a matter of who communicates. It's partly a matter of how you communicate. And there's a whole psychological literature on what's called procedural justice about how you relate to people in order to give them an understanding that you are, for them rather than trying to control them, which is the critical issue, I think.
Lovely, thank you, Prof. I just wanted to bring Heidi in from the Society of British Dental Nurses. Have you found that this is kind of like the theme that's coming through from your perspective at the Society?
Yeah, absolutely. What we've done is obviously from the questionnaire that we put out to our members, a lot of them, it was more about the hesitancy rather than not wanting it. I think it was mixed messages that were coming across, and some of the untruths, and it was who to actually believe. I think seemed to come across a lot in the questionnaire and the answers that we got. And I think a lot of people were objecting. It seemed to be more to being told what to do, which obviously, Stephen, you adhered to that. People don't like to be told what to do. I think it's about their choice, being given that choice.
Yeah, and I think one of the other things that seems to be coming up as a common question is we still don't know what the long-term effects of the vaccination is. So I'm going to go back to Stephen. Do you want to, sorry, Jason, do you want to give that a bash?
Yeah, well, it's true that we've only been vaccinating for COVID since, what, December 2020 for research, March 2021 in broader populations. But the technology has existed for 100 years. This is not new technology. There is a new element to the way we are making vaccines in order to make them more effective and make them faster so we can produce them quicker. But the basic technology is Edward Jenner and smallpox. If you give somebody a little piece of the disease, you prepare them for the actual disease. Now, in Edward Jenner's day, he was using actual virus from an animal to protect humans from a different human virus. We don't need to do that anymore because we have technology that can divide the virus into its constituent parts. We can take a little piece of its non-infectious bit, so you need the whole virus to infect you. The virus does actually look not unlike the BBC version, like the football with the spikes on it. It doesn't quite look like that, but it looks a little like that if you look down a microscope. So you get the ball and the spike proteins, and it's the spike proteins that attach to your cells and then enter your cells and it divides. That's how it works. That's its only mission. That's what it wants to do. So you take a little tiny piece of the spike protein. Remember, the spike protein by itself is completely harmless. It cannot do anything to you. The conspiracy theorists have this whole thing about the spike protein. It's absolute gibberish. So the spike protein by itself is completely harmless. That we make that into the vaccine and we then give you that. So I am very, very confident that there are no long-term side effects of the vaccine. However, I know for certain that there are long-term side effects of COVID. Absolutely for certain.
Yeah, which we've seen that in the news and in the public eye. So.
Huge numbers of people with chronic disease after the acute infection. So even in young people who won't be in intensive care on a ventilator and are at very low risk of death, having long post-viral disease after a relatively mild episode of the acute version of COVID. Now, we don't understand long COVID yet properly, but we know it exists and we know it's significant. And we know that its damage will be in the working age population because it will be young men and women who are dental nurses and hygienists who will be trying to function with their young families, with their work. So I know for certain that the long-term effects of COVID exist. The long-term effects of vaccines, I know from all the vaccines we've given over 100 years, don't affect people.
So just on your point, so the dental nurses and our dental profession. Let's bring
Steve has his hand up.
Could I make a couple of points?
Go for it.
I mean, one was just to come back on that point of people don't like to be controlled. There's a whole psychological literature on what's called reactance. If you try and take people's autonomy away, they will reassert that autonomy. And I mean, they will assert it in doing things they don't particularly want to do, but they just want to say, I've got a right to do it. And I don't want to infantilize people, but every parent knows that, right? If you say to your child, you're going to bed, even if they're desperate to go to bed and their eyelids are drooping, they're going to say, oh, no, I'm not. So you say to them, do you want to go to bed in 10 minutes or 20 minutes? And they say in 20 minutes, and then they're in bed. So trying to control people does tend to lead to reactance. The other thing is that if people have concerns about control, often it's because they've got good reason to have those concerns for historical reasons. So if you look at the figures on vaccine hesitancy, they are higher in populations which historically have had problems of trust and relationships to authority. They are higher amongst more deprived groups. They are higher amongst unemployed people. They are higher amongst religious minorities. They are higher amongst Black communities. A couple of years ago, I'm sure you'll know this, there was a joint report of the House of Commons and House of Lords in the UK, which showed that 2/3 of Black people have a sense that the health services don't prioritise their concerns. And so the fact that you get higher proportions of hesitancy in particular communities, again, has got nothing to do with information, nothing to do with irrationality, not because they don't understand the facts, but because there are issues and historical issues of trust. And you've got to work to those, and you've got to acknowledge that people have got good reason to have problems of trust. If people have questions, they tend to be perfectly sensible questions. If they have distrust, they have reason for distrust, because historically there are some very murky incidents indeed. So I think that's really important to take into account. Now, there was a second point that I was going to make, which I've now completely forgotten because
That's
I
right.
because I was
got your hand back up and we'll pull you back in. I was going to just thinking about trust and people's autonomy, where we've got quite a fair size of the proportion of our dental profession, such as the dental nurses, who haven't been vaccinated. They may feel that that's an invasion of their autonomy. So come April 2022, what's going to happen when we look at this from a legal perspective? So I want to bring Sarah into the conversation now. And if you could just maybe give us the scope of kind of what the legal basis is for employers in primary care and secondary care of having staff who are unvaccinated.
Yeah, thank you. I think it's really important because I think for people to understand that this is affecting not only the NHS but private dentistry. I think I speak to a lot of people who still believe that it is only applicable to NHS dentistry, and it's not. It's for anyone who's regulated by the Care Quality Commission in England. So I think that's the first point. I think the second point to know is that people obviously I've been advising on this a lot, but in my opinion, there's a lot of people that think that there's going to be some alternative, that I'm not going to be vaccinated, but what happens to my role? What do I do instead? Well, the answer to that is that you probably will not have a role within the dental team, because within the dental team, within the dental practice, they're fairly small businesses, and they can't look to redeploy you into a role where you're not patient facing. So every member of the team, whether you are seeing a patient or on reception, hygienist, therapist, whatever your role is, you will have to be vaccinated, and it's double vaccinated by the 31st of March. If you're not, at that point, it will be illegal for your employer to continue to employ you. And without going too much into the ins and outs of the procedure, what will happen is eventually you will lose your job, you won't be able to work within the dental sector in England. And what's happening at the moment is that for when people are employing and engaging new individuals, whether they're self-employed or employed, I made that really clear as well, that it applies to self-employed. Some people think it doesn't apply to the self-employed sector, and it does. That when you're looking for new work, it will be a condition of your employment. So you will only be offered that role when you can prove that you've been double vaccinated or that you are exempt for medical reasons. So the reality of the situation is that if you don't want to be, or don't want to be double vaccinated, and you haven't got any mitigating circumstances, that your job is at risk.
And what happens if the government or the JCVI decide that actually you have to have that third dose booster? We know from the provisional interim results from the survey that around 32% of the dental nurses were not planning on getting the booster. What would happen in that case?
Well, the legislation at the moment doesn't cover the booster. All they're asking for is for the 2 jabs. So I don't know if they're going to bring that in and going to make it mandatory for health and social care workers. There's nothing that I'm aware of. I mean, this has been brought in, first of all, for care home workers. So it's already in place for them. They had until the 11th of November. And as far as I'm aware, there's nothing for care home workers in England where they have to be boosted. And the dental industry and the health and social care workers that we're seeing now is following suit. So I don't know what will happen with the booster, but I imagine if they do bring it in, they will be provided with grace period to allow the team to go and get boosted, to go through the employment legislation procedures that you have to go through to protect yourself from any tribunal claim and so on.
Okay, so it really is, it's not just affecting dentistry, but it's actually affecting all areas of healthcare by not having a vaccination. So even if you chose not to progress with dentistry, you couldn't really go into a patient-facing healthcare profession in the future without actually having the vaccination.
I think that's where people become a little bit confused, because a lot of the information we're provided is for the wider NHS or the wider medical care profession, where you can work for the NHS and not be patient facing in some other roles, so they will be able to get away with not being double vaccinated. The thing with the dental team and how the dental team works is that there isn't a role within the dental team where you can't be double vaccinated. So they may be able to come out of the dental profession and move into other sectors within the NHS, but they wouldn't be patient facing, and that's the key. And this is where it becomes confusing, because some of the guidance says if you're not double vaccinated, you'll be redeployed into another role. You can't do that within the dental team. Yeah. That doesn't work. It works in other sectors, but not for this industry. So actually the reality for this industry is that if you're not double vaccinated by the 1st of April, it is your role, whether you're employed or self-employed, NHS or private, that is at risk, because you won't be able to work within the dental practice.
And I just want to bring Stefan in now. From a dental public health perspective, what's the impact on our patients and the care that we're going to provide?
Yeah, that's a very good question, really. And just as a adding also to Sarah's point as well, we provide advice to dental teams within Yorkshire and Humber, our dental public health team, when they have similar queries, and we get them on a weekly basis coming from various practices. In terms of the impact, essentially NHS England is looking, and I'm aware there were conversations with the BDA as well, in terms of the impact on workforce. The BDA had, I think, a survey just recently on looking at what impact it would have on the workforce. So we know there is a shortage of dentists and dental nurses, hygienists at the moment for various reasons as well. And this might impact on the workforce further on. So it's always finding that balance somehow in terms of obviously the risk associated with not being vaccinated, but also the impact that it will have on the workforce.
Yeah, so we've got this 50 million being injected into dentistry up until April 2022, but then the real risk is that we're going to lose a chunk of our workforce because of the vaccination mandate. Hence why, as the College of Dentistry, we're encouraging that it be deferred until our workforce can get into a position when they can get vaccinated. For patients, do you think they'll be worried about dentistry or not, or do you think?
Well, access is a huge problem at the moment. Everybody knows that because the restrictions with COVID early on, and then the backlog that has been created additionally, access to dentistry is a big problem at the moment. So that 50 million that you mentioned is to support to some degree that access issue. But patients obviously are desperate to see a dentist, and it just increases inequalities as well, both geographically as well, because there are certain regions that are more affected than other regions, but also in terms of the economic, social inequalities that patients are facing in terms of being able to afford to access dentists in certain areas as well, both privately or being able to access via the NHS. So it's a tricky one, of course, at the moment. But yes, access needs to be one of the things that are taken into account.
Yeah, absolutely. Has anybody got any questions that they want to direct to each other at the moment? Well, I'm going to start to do a bit of a quick fire question round for all of you. Does that sound okay? Yeah, okay. So what exemptions are there to vaccinate? So that's just come in on the chat. So I think I think that means maybe vaccination, if exemptions to avoid getting the vaccine, maybe.
Yeah, so Sarah will give the legal position. The clinical position is that you can get a vaccine certificate exemption to travel, to go to a nightclub in Scotland, if you have a very, very small number of rare conditions that stop you being vaccinated. But it's quite unusual. You can't just choose because you're a bit worried about allergy, for example. You would have to have a very, very good reason not to be vaccinated. You could, for example, be in end-of-life care, and vaccination would not be something we would do then. You could be inside a very serious part of your chemotherapy regime. We would want you vaccinated, and you would want to be vaccinated in the main, but during that particular period of your chemo, you wouldn't be appropriate to vaccinate because you have no immune system and it wouldn't respond properly. So it's quite rare to be medically exempt from vaccination, but not impossible. So I imagine the legal position is if you have one of those rare reasons, then you are exempt from the legal requirement. Okay. But Sarah's the lawyer.
Sarah, do you want to?
Yep, so it's medical conditions, and you would have to have, it's not up to the individual to decide on whether that medical condition is an exemption. You have to have proof of that exemption, and that's either from your GP, or there is a certain a helpline you can phone to get the exemption to download it onto your NHS pass. So for example, it may be severe allergies, like it's been said, it may be forms of asthma, adverse reaction, you were in COVID, you're part of a COVID clinical trial. So the other exemption that we haven't spoken about as well is pregnancy. That if you are pregnant, you are exempt by virtue of your MAP B form, which is the form that you're given when to set out the date in which the pregnancy, when you're due to give birth. So there are numerous exemptions, but it isn't down to the employer, the employee, or the self-employed person to decide on whether they fit into that category. It's actually going beyond that and looking for the evidence, and that will be medical evidence if you are medically exempt, or your MAP B form if you're pregnant.
So let's be clear though, Tashfeen, the advice for pregnant women is to get vaccinated. That is the advice. Very, very strong advice, stronger advice than for the general non-pregnant population. So that legal difference must be about being able to work without the mandate, but in England. But the very strong advice for pregnant women, because we are seeing unvaccinated pregnancies inside intensive care units all over the country. Yeah. And it's really scary. Yeah. So the advice for pregnant women is to get vaccinated.
Yeah. And I've seen a patient when I was doing an urgent dental care session, and she was telling me that she had to have her baby induced early because she'd caught COVID, and it was just really dangerous for her. And she just said to me, I wouldn't wish that on anyone. So thankfully she had her baby. She was, she came to get some urgent dental care treatment, which was good. But when you see your patients firsthand who have had COVID and they tell you the horror stories that they've gone through, it's just not nice. So yeah, that's a very clear, defined message that if you are pregnant, make sure you've got your vaccine because it's going to protect you. Okay, I've got another question here. It says, who is taking personal liability if this damages me?
Just raised her hand.
Sorry, Tashveen. I was just going to ask Sarah, if you don't mind.
Yeah, go for it.
Because it might be of interest. And it came up and we had an inquiry about this. You mentioned about COVID trials as an exemption. Is that historic trials or things that are going on now? Sorry, I don't know if you know about that. I'm not sure.
It's a good question. But my understanding is that when you're taking part, they give you a letter which basically states whether or not they'd like you to have the vaccine. It's all very official. So again, you're looking for the proof behind it. Yeah. So if somebody came to you and said, I'm exempt because I'm taking part in a trial, they will have been told that. So we will want the information from where the trial's been held. And I've seen letters come in where they've said this person is exempt and shouldn't be double vaccinated at this time. I don't know what the future is going to hold. So I think it will depend on the trial. So just as an employer, or if you are an individual, you'll want to be getting some form of documentation or evidence from that trial.
Brilliant. Thank you so much. See, I learned something tonight as well. Thanks, Sarah.
And I think some
of them. Thank you, Tashveen.
I think some of the trial data is being passed through to GPs now. So if you know somebody that's on a trial, they should be able to get that information relatively easily. Okay, we've got some questions on the chat here. It says, what data proves it is safe in pregnancy for the unborn babies? So have we got data on this?
We have. We've got data in both directions. We've got data of the effects of COVID on pregnant women and unborn children, and it is horrifying. It's absolutely horrifying globally. And we've got very good data now on tens, if not hundreds of thousands of vaccinated pregnant women and no harm coming to either the woman or the baby. Very big trials. There is no mainstream obstetrics organization in the world that says you shouldn't be vaccinated.
Okay. So, Stephen, nudges. What kind of nudges should we be using to encourage people to get vaccinated? You're on mute.
I don't like the term nudge. This is me being a bit of a psychology nerd. The concept of nudge is rooted in behavioral economics, and it's rooted in an assumption that people don't really know their own minds. And as a consequence, what you have to do is to change what's called a choice architecture, so they change their behavior without realizing it. Now, it's a psychological approach, which to me is actually problematic because it suggests that you can't reason with people and you can't talk to people and you can't be open and persuade people if they don't know their own minds. And to me, that's problematic precisely because it undermines your relationship with people. It stops you treating people with respect. Now, I know people in ordinary language use the word nudge in all sorts of different ways, not meaning that. They mean what sort of interventions can we have? To me, there are a number of factors which are absolutely crucial, and they go back to some extent to what I was saying. But one of them that I wanted to stress is, again, the need for openness and the need for honesty and the need to recognize deficiencies. See, one of the problems I think of the whole pandemic debate is it's being conducted in a terribly binary way. Things are either perfect or they're awful. And the danger is that if you say something is perfect and you find one counterexample, then people will flip-flop into, you said it was perfect, it isn't, I can't trust you, it's awful. And I think that's happened with the vaccines as well in two ways. First of all, I think it's really important to acknowledge the counterindications. I mean, back in the day when vaccines were coming in and people were saying this is a terrible problem, I used to get out, my pack of ibuprofen or paracetamol or whatever it is, and read out, what's on that. Now, if that put people off, nobody would ever take a headache tablet. But all of us know these are possibilities. They're incredibly rare possibilities, and they don't stop me taking a headache tablet when I've got a headache. But if, for instance, one person in many millions was affected, it wouldn't put me off. Equally, we've got to make clear to people that there will be concurrent events. I mean, if you vaccinate everybody, some people are going to die of all sorts of things, but they'd have died anyway. And the final thing is, and I think this has been a problem, that the vaccines are wonderful. The vaccines are the best tool we have for dealing with the pandemic. There's no doubt about that, but they're not perfect. We know they're not perfect. We know they don't absolutely stop infection, transmission, hospitalization, death. And if people talk about the vaccines as if they are the sole and the perfect solution, again, if there are problems, people will reason and say things, well, if vaccines were so wonderful, why have we still got, a wave of infections? Why are these things happening? So I think being candid and making a very simple argument, which is they're not perfect, but they're a damn sight better than not having the vaccine. Now, people hesitate to do that precisely because there is this belief, this nudge belief, that people aren't very good with dealing with complexity, and they aren't very good with dealing with uncertainty, and they aren't very good with dealing with probability. The research shows, more recent research shows, that we shouldn't be so pessimistic about the human psyche and so condescending towards the public, that actually, as long as you're open and you are clear and you make the points about it's not perfect, but it's better than not having it, that actually that increases trust and that increases willingness to take things. So in the end, everything I've said boils down to one very simple thing, right? You don't need to overstate the case. The case is so strong. Jason has laid out the case. The case is so strong that yes, there are going to be some uncertainties. And yes, there are going to be some negatives. But the negatives of not taking the vaccine by far outweighs it.
Okay, thank you. We've got an ethical question here. It says, don't you think get a jab and we will give you a free kebab is a very unethical way to push COVID vaccine? Do you want to take that one, Stephen?
Well, actually, there is quite a lot of research which shows that the role of positive incentives is actually rather mixed. Okay. So number one, if it's only worth a kebab, people will reason it can't be that good. It can't be that important. So sometimes incentives perversely leads you to undervalue something. There are a number of studies in the States, using lotteries and so on. However, I think there is a different way of proceeding, because one of the important things we haven't talked about so far is the role of group norms and the role of, if you like, group cultures in terms of promoting, well, any sort of behavior, but including vaccine behaviors. Okay. And if what an incentive does is it says, this community values what you're doing, right? This value wants to help people who help themselves, and help people who help the community keep themselves safe, then you can use incentives in some ways, but not as an individual act, but as a symbolic act that we as a community value and want to applaud what you're doing. And therefore, again, it points to a slightly different process, that it's not about, individual incentives. It's very much about groups, about trusting those who talk to you, about a sense of the groups that you value, valuing these behaviors, that the groups that you value supporting these behaviors. So I think there is a role for incentives, but I think they've got to be incentives that come from the group to which you belong. And I think they've got to be incentives which are far more powerful because of their, if you like, symbolic value rather than their material value.
Yeah, I agree. Sarah, do you want to add to that?
Yeah, I think there's a small incentive that maybe employers can provide to their staff, which I think is often forgotten about, but actually helps a majority of people that just haven't been vaccinated, because I hear lots of team members who haven't had time, it's too far away, I can't be bothered with that at the moment, I've got so much on. That there are people saying things like that. So from an employer's perspective, it can be as easy as saying, I tell you what, leave at midday today and go to a centre and pay them for it to just go. And I know it's an incentive in a different way to a free kebab, but it does really help with people, especially the group of people who are saying, I don't get round to it, I haven't got the time. The one thing that as an employer you can provide to them is the time to go and do that. And I think sometimes that's overlooked because it's quite a small thing in the grand scheme of things, but it's helped a lot of my clients.
Yeah. So Diane,
can I come back on that? Sorry, can I come back on that? Because I think that's a really important point. And I think you're absolutely right. For those who don't get vaccinated, not because of the vaccine, but for, because they couldn't be bothered because of practical reasons, one of the key things that has come over again and again and again in the pandemic behaviorally is that actually in many ways the issue of opportunity and support so people can do things is absolutely critical. If you look at self-isolation, why do people not self-isolate? Because they find it very difficult to do so. Early on in the pandemic, there was a study which showed that poor people from ethnic minorities were 3 to 6 times more likely to break lockdown, right? But not because of motivation. Their motivation was identical. It entirely had to do with their ability to stay home and put food on the table. So support. We should be thinking not about pressurizing, punishing people, but supporting people. And there are 2 issues which I think are really important. One is, I absolutely agree with this, paid time off to get vaccinated is really important. And the other thing is to make sure that, if you are a little bit under the weather for a day or 2 after vaccination, that happens to quite a lot of people. It's nothing terrible, but you just feel grotty and you want to stay at home in bed. There is paid time off to do that as well, because for some people, in precarious conditions, not particularly well paid, the notion of losing a day or 2's pay is just not, you can't imagine it. They can't survive without it, and therefore they're not going to get vaccinated because of things like that. So support, practical support in terms of time off, both to get vaccinated and any sort of minor post-vaccination, not feeling a bit under the weather. I think that's a really key point. Support people. Don't shout at them, as Jason apparently is prone to do. Don't pathologize them and treat them as stupid. Right? Don't try and bully them into things. Support things. And the good thing about support is it gives you a double advantage. On the one hand, right, it makes it possible to do those things, but on the other hand, it shows them that you're on their side. Right? It creates that sense of in-group inclusion that undermines the anti-vaxxer narrative of they're not for you, they're trying to control you.
Yeah. I just want to bring Diane and Heidi in. So have you had this experience as part of the groups that you're responsible for? So I'm thinking of dental nurses who may have children in school age who have to leave early. Are you finding that this is part of the narrative that they're coming through with when they're responding to your surveys?
Yeah, absolutely. From a dental nurse perspective, I actually work with students as well.
Okay.
And we're, as part of the site I'm on, we've actually got a vaccine centre on site. So actually, the students have also been encouraged from our side, but also they're given time out of their training to be able to, because obviously I deal with anybody from 16 upwards. So obviously we've been supporting with that it's on site and they can actually use the walk-in centre while they're with us. So we're also doing that as well. Obviously, from a perspective of obviously the surveys and things that we've been carrying out, obviously it's just, I feel like it's the supportive measures at the moment. It's answering queries, and pointing them to the facts, rather than, scaremongering or anything like that. And I think that's key at the moment. But obviously, from my perspective, obviously being, working with trainees, it's making sure that support mechanism's there, and working with the employers as well has been key to that. And I think that's been, all our students have been vaccinated. They've all done it. And that's not from, the pushing or anything like that. They've done it with the support of everybody around them. So, and I think that's really positive.
And within your organisation, have you provided quite a lot of vaccine education to your members?
Yes, absolutely. There's been lots of things that we've put out on social media. Obviously, as soon as things come out, and then obviously because through sort of the question and answer sessions and the newsletters that go out to members, it's to point them in the direction of the actual facts.
Yeah, lovely. Diane, did you want to add anything to that?
Yeah, I think we haven't, just looking at our sort of feedback as well, we haven't had too much in the way of, time, and that's not the reason. It is generally more, I think it is more the support and that educational value as well, and understanding, why we need to have the vaccine, that really, and I think just looking through some of them, there's a lot of comments about it. A lot of the members that replied to our survey is very much more focused on, the science, the evidence. And so I think it's directing them in with regards to the science, and the evidence with regards to the vaccine. And those, and actually looking at it as well, there's a lot, that have had the vaccine, but they disagree with the mandatory side of it. And it's that, as we were talking about before, it's that control as well, and that control being taken away from them. So while they've had the vaccine, they're not really, so I think it's more that kind of educating and pointing them in the right direction of the research and the evidence as well. And I think that's how we've been supporting as well, and offering that support to our members.
Brilliant. Another quick fire question. So can you please advise me, if I were to experience any adverse reactions, is the manufacturer of the vaccine liable? If the manufacturer isn't liable, will the company I'm currently employed with be responsible and liable, as it is their request that I have the vaccine in order to carry on my employment?
So this is a conspiracy theory. This is a long, dark tunnel that's used by the conspiracy theorists to confuse and scare people. This vaccine is no different from any other healthcare intervention. And the liability lies in exactly the same directions as it always lies when you consent to a healthcare procedure. So the principal liability lies with the registrant, the person who gives you the vaccine or consents you for the vaccine. So that could be a dentist, it could be an optometrist, could be a nurse, could be a doctor. And they are trained in vaccination, they're trained to answer your questions, and they're also trained that when they reach the end of their expertise, if you're a particularly complex patient or you've got questions that they can't answer, that there are hierarchies within their clinical environment where you would go to next. So I am a vaccinator. I have done vaccine clinics, partly for PR purposes to make people show up, but also a free selfie with every vaccine was my tagline, but it didn't really work, national treasure or not. But there are some questions I couldn't answer, but there were people in the room who were better than me, who had been doing it for longer than me, like every clinical team. There are then, of course, liabilities within the manufacturing of the drug and the vaccine, just like there would be if the paracetamol pack was dirty, or the blister pack was burst, or the medical information leaflet wasn't in it. And then there are hierarchies of liability and authorization within every health board or trust that is giving the drug. Now, mandation, I'll have to go to Sarah, but the fundamental healthcare implications are exactly the same as having a hepatitis B vaccine or having some chemotherapy or having your tooth extracted. The liabilities are exactly the same. There is nothing different. So there is a conspiracy theory that Pfizer signed away its liability to governments. It is gibberish. It is absolute gibberish. So the liabilities lie in exactly the same lines as they lie in every medical procedure that you could possibly get. Vaccines are no different.
Brilliant. So you heard it here first. So there you go. So next question.
Sarah might want to give the legal position if I haven't covered it with my use of gibberish.
No, I was going to say that's absolutely spot on, and I think it's disappointing that somebody would think that their employer would be liable for it because they're being put in a position where they are enforcing some law that's come into place. That isn't the case. They are just following the rules and regulations. And I suppose that comes back down to the amount of trust between the employer and employee, which is there. But what I would say that from an employer's perspective is that where the employer may end up being liable in respect of all this is if they don't follow a fair and reasonable procedure or don't provide the required notice periods from a contractual perspective. So for anyone out there who is dealing with team members who are not, for whatever reason, going to be double vaccinated, they must take advice on how to bring that relationship to an end to ensure that they don't end up in an unfair dismissal situation or don't have to breach of contract. But that has got nothing to do with the fact that this is a law and all the employer is doing in this situation is following the rules and regulations.
Yeah. Stephen?
Right, I'm just sorry. This is awful. I have to give my apologies because I have to do something at 8:30, and it has to be set up now. I'm really sorry about that.
Thank you so much for joining us. It's been wonderful to have you join us.
Can I say that being in a room full of dentists is about as terrifying to me as being, I don't know, in surrounded by traffic wardens. But it's been very painless, and it's been very enjoyable. So I've tried
to. One of the ways to get over phobias, Steve, is to drip feed you the thing. So I've tried to do that over the last 2 years. This is your final. This is the final act.
Yeah. I never realised you were that useless, Jason.
That's what we were doing.
Thank you so much, Stephen.
Okay.
Really,
so thanks everyone. I'm sorry for rushing off.
That's great. Thank you.
Bye.
Okay, I've got another quick fire question. Can you please explain the list of injuries and death on the yellow card?
So this again sounds as though it's partly conspiracy theory.
Okay.
So the yellow card is the way we report the adverse events for any drug or vaccine. So you can write on there that you had a sore arm. Mm-hmm. You can write on there that you had an allergic reaction. Individuals can do that, or healthcare workers can do that. And we collect that for all drugs, from paracetamol to chemotherapy and vaccines. Yeah. And the MHRA and others review that data regularly. And if anything is flagged, so if you remember right at the beginning, when we were giving the Pfizer vaccine, right at the start, we had 2 people who had very severe allergic reactions. And we adjusted the instructions about the vaccine because of those 2 incidents. It turns out that it was quite unlucky, that there were some allergies, but actually when you did 20 million people, you actually didn't get 2 a day. You got 2 a day randomly in the first couple of days. So actually the allergic, when you began to do tens of millions of people, it became apparent that that actually wasn't the major challenge that it seemed to be at the time. Then we've had other issues with some cardiac challenges with individual, particularly some age groups, some genders, and some pre-existing conditions. And we've adjusted the advice accordingly. So the yellow card scheme is part of our mechanism for feeding back lists of side effects and adverse events, and we adjust the program appropriately. You will see, if you're in the dark tunnel on social media, fictional lists of what the yellow card scheme has allegedly reported into the MHRA, it is not true.
Yeah, I can see. We've had a few of those sent through to us, and it looks like the yellow card scheme. It is the exact replica of the page, but when you actually check it, unfortunately, it's a duplicate down a very long dark tunnel with completely inaccurate results on that.
One of the things that has surprised me is the organization of the anti-vax community. It is very, very well organized, often not in this country, often in other parts of the world, but it is, they sent a letter to every school in Scotland that looked like a consent form that was to be sent to every parent, and it was full of lies and misinformation. And the schools fortunately spotted it, but it had the NHS logo on it. They're very, very organized.
I've got one question for you. Are there any other countries that have mandated vaccinations for their health and social care workers?
Yeah, I don't know the whole list, but there are many. Scotland is a bit of an outlier in not. We haven't done it.
So one out of the 4 nations in this country have. So what's the reason why the other 3 haven't?
It's a good question, and I would never openly criticize another country's response. It's that way lies extreme danger, because this is a really, really hard thing to manage, and it's been really tricky. Our assessment of our level of vaccination amongst health and social care workers is that we don't need it. We have very, very good coverage. We also listen to Steve. Steve is one of our principal advisors on behaviour. It's not straightforward. It's not a yes, no, you should never do it and you should do it. But for our level of vaccination coverage in our health and social care workers, which is pretty much 100%, it's pretty much done, certainly in social care and in care homes and most of healthcare. There are very few mainstream healthcare workers who don't wish to be vaccinated to protect themselves, their families, and those they care for. Other countries have more of a challenge. So in the US, there are vaccine mandates in some states. There are vaccine mandates in some public sector employers, not just health and social care. So different countries attack it in slightly different ways. Scotland has chosen not to.
Yeah, I think.
But that doesn't mean we would never. That doesn't mean we would never do it. We've always said that. But there's no suggestion of doing it just now. We do mandate hepatitis B vaccine for those who are patient-facing in surgical roles. So we do have some mandated vaccines.
I know from my research that Indonesia, Italy, France have made it mandatory in their countries for health and social care workers, and other countries such as Austria, Germany, and New Zealand have got it in the pipeline as well. So we're not an outlier. We are more than likely to be on the same parallel as other sort of first world countries. Another question, there's been a lot of discussion regarding which vaccine to take. What are the differences between them?
Yeah, there's pretty much no difference, meaningful difference. You should take the one that you get when you turn up at the clinic. So there are some preferences for some age groups. So for instance, we have a pediatric version of Pfizer. It arrived yesterday in the country. We started giving it today. And we gave our first pediatric dose today in Edinburgh. So you should take the one that you're offered. There is no real meaningful difference in the research to where you end up in terms of immunity.
Yeah, lovely. We've got here another question. In Northern Ireland, our health minister has previously stated he will be consulting the public on this, but so far the public consultation has not been launched. So Northern Ireland is still looking into that. Hep B was rolled out 20 years before it was mandated, isn't that right? Plus Hep B is a lot more sinister. A young healthy person can fight off COVID.
That's not true. That's absolutely not true. Most young people can fight off COVID. There are some young people dead because of COVID. Some healthy young people have died of this disease. Some pregnant women, otherwise healthy, have died of this disease. And hepatitis B isn't contagious. COVID is contagious. You can give it to those around you. Your grandmother, your kidney transplant on the bus that you don't know is there, other diseases. So that's why you have I think, a civic duty to be vaccinated, to protect yourself, but also to protect those around you.
Yeah, thank you. I'm going to hand over to Rob now, because I think we're hitting our 8:30.
I would agree. I would agree. Absolutely fantastic. Thank you so much, everybody. Thank you, Jason. You've been getting some serious positive tweets about your performance tonight, mate. Great one. Really impressive.
That'll be unusual.
Well, there you go. Yes. Yeah. You may have paid them, but no, thank you so much. Thank you, Jason. Thank you, Heidi. Thank you, Dan. Thank you, Stefan. Thank you, Sarah. Obviously, thank you, Stephen. He's gone. And most of all, thank you, Tashmeen, for hosting and chairing tonight's event so wonderfully. An excellent event, a huge amount gone through. Jason Wong had given us a video. We didn't have time for him. He just mentioned to me, he didn't make the cut, unfortunately. So I'd like to thank you all for this evening. It's been incredibly helpful. I know we got through most of the questions. If you still have any concerns, you've got my email me directly, and we will do our best to help you make the right decision for you. That's the key thing. Okay, thank you so much, everybody. The recording of this will be available tomorrow, and we will also be turning it into, or some bit into, a podcast, as long as everybody here is happy. It's just a question of getting the information out there in the short period of time that we have in England. Okay, thanks very much, everybody. Take care, have a good night, and we shall see you all very, very soon. Take care.
Thank you.